Good morning. And thank you so much, Dr. DePetti, for such a kind introduction. And it's a pleasure to be here. Never been to Key Island, even though I live in Columbia, South Carolina. So it's really nice to be here and to have the pleasure of kind of getting to know you all over the course of the next 3 days. So what I'll talk about is the magnitude of the problem, depression, that we all kind of encounter within not just the primary care setting, but in healthcare as such. And then talk about treatment, both kind of non-pharmacological as well as pharmacological treatment interventions. And normally I have a tradition of opening with a joke. Are you all in the mood for a joke? All right, here goes. So Sherlock Holmes and Watson decide to take a camping trip in one of the parks in London. So their housekeeper cooks them an elaborate meal. They take some wine alongside with them. Pitch a tent on the camping grounds and have their dinner, pour some wine, and call it a night. In the middle of the night, they're woken up by a loud thud. Holmes wakes up first, looks around, wakes up Watson and says, Watson, what do you see? Watson wakes up, looks around, says, I see the dark blue sky, I see the silver crescent moon, I see the twinkling stars, and on and on and on. By now, Holmes is at his wit's end. He kicks Watson and says, Watson, you fool, somebody's stolen our tent. The moral of this is that things that may seem obvious are often missed, which brings us to behavioral health. While we all acknowledge that there is a problem, that we need to address it, but more often than not, it's just like guns and mental health, right? We talk about it, nothing gets done. So to me, let's talk about depression. This is something I'm very passionate about. When I was at Yale, Dr. DePetti alluded to one of his medical classmates who clearly was my mentor, Dennis Charney, who is now at Mount Sinai, who's the dean there, who clearly taught me a lot about depression, clearly clinical trials. If you look at the magnitude of the problem, 330 million individuals all over the globe suffer from depression. It's a ubiquitous problem. If you look at the United States alone, lifetime prevalence is about 17%. And when one looks at dailies, which is the disability-adjusted life years, depression is the second leading public health concern. And very soon, in the next decade or so, if not sooner, it's going to surpass heart disease. So each one of us in this room and beyond need to be in a position to be able to recognize depression, one, and then to be able to accurately diagnose and treat depression. And we all know the average age of onset is kind of in the mid-20s. And again, most of them have the first episode around the middle ages in the 40s. Duration is anywhere from 6 months to about 2 years if left untreated. Male to female is about 1:2. Now, despite all the progress that we've made in understanding the neurobiological underpinnings of depression, as well as the treatment advances, we have more than 30 antidepressants that are out there. Yet, we continue to grapple with stigma. And we're talking about this in the 21st century. So we, as providers, from different specialties, need to do a better job in being able to improve awareness on depression. Access to care is a significant issue. If you look at the state of South Carolina alone, we only have about 600 psychiatrists in the state of South Carolina for about 4.9 million lives. Just to give you a context, in India, where I come from, for a little over 1 billion lives, they only have 6,000 psychiatrists. So when the World Health Organization says depression is the second leading public health concern, how do you go about addressing it? So access to care is a significant issue with mental health providers. So it's not just about increasing GME slots for psychiatrists or psychiatry trainees, but also how do we increase the pool of nurse practitioners? How do we improve psychologists, social workers? How do we start to work towards the healthcare landscape, which tries to help in terms of building these teams that will help improve access to care? It's also important not just to focus on effectiveness in terms of efficacy and tolerability, but also in terms of what are other factors that do play a role in terms of improving adherence. If you look at adherence in medicine, I mean, look at hypertension, for example. The rates of adherence is anywhere from 45 to 50%. Taking the medications, antihypertensive. In depression, it's like the first month of being put on an antidepressant medication, it's about 40% of those individuals are completely adherent to their medications. So vast majority, the other 60%, are either partially adherent or completely non-adherent. 3 months into, the rates of non-adherence is about 72%. So it's extremely important for us to start looking at it not just from efficacy, tolerability, but more in terms of kind of globally, how do we start to look at what are the barriers to treatment adherence? Of course, we're trying to make psychotherapy more available. As you are looking at fewer MDs, how do we start to train the kind of mental health workforce in terms of being able to render with CBT, interpersonal psychotherapy, and all of which we'll talk about today. We've also seen a paradigm shift in how we look at treatment goals. We are no longer satisfied with response, which is a 50% improvement from when you inherited the patient, the baseline, to when you got to kind of start them on the medication, 6 weeks, 12 weeks into. Is there a 50% reduction of the symptomatology? That's response. Remission is a higher standard. It's an improvement not just in the symptomatology, but also in terms of kind of their social occupational functioning, which then lets them on to this path to recovery, which is an improvement in the overall quality of life. How do you start to integrate them back into the community? And that's the highest standard. So to me, it's not just response that we need to be satisfied with, but getting them on to go to remission and recovery. And how do you make sure that it's an individualized treatment? One size does not fit all. So within the primary care sector, this was an interesting study done by Frank and colleagues who looked at patients who presented with somatic symptoms, right? More physical complaints, aches and pains, gastrointestinal distress. And take a look at this. So the blue bar represents anxiety disorders, the orange bar represents mood disorders, and any psychiatric disorder, the yellow bar. So the more the number of physical symptoms the individual presented with, the more likely they are to have behavioral health issues. So there is a bidirectional relationship between physical illness and mental health issues. If you look at cardiovascular disease, for example, there's a very high risk of kind of depression in those who have had an MI, those who have any kind of ischemic disorder, ischemic heart disease. So it's important for us to be able to recognize that. Now, the US Preventative and Services Task Force really recommends that we start to screen people for depression within the primary care sector. Something as simple as the PHQ-2, which asks for these 2 questions. Over the past 2 weeks, have you felt down or hopeless? Over the past 2 weeks, have you felt little interest in doing things? If the answer to that is yes to either of those questions, then you can do a PHQ-9. And now with kind of digital technology, you can even have a kiosk or an iPad where the patient can do some of that, and by the time they come to you, you already have the PHQ-9 score. And this is what a PHQ-9 symptom checklist looks like. I know that Joan is going to be talking about it tomorrow, so I'm not going to kind of belabor going into some of the details here. But as you will see, it's lack of interest, depressed mood, trouble falling asleep, staying asleep, or sleeping too much, hypersomnia, feeling tired all the time, little energy, appetite. So SIGA-CAP is what you're looking at predominantly. And when you look at the PHQ-9 scores, 1 to 4 would be kind of, you're looking at minimal depressive symptoms, 5 to 9 is mild, 10 to 14 is moderate, moderately severe is 15 to 19, and severe is 20 to 27. And take a look at the mean disability associated with each of those. So clearly, if you have severe, moderately severe, or severe depression, look at the mean disability days. Might be significant. Symptom-based difficulties, so here is where you get into kind of folks who clearly are extremely depressed, which then correlates to physician visits, new physician visits, which is healthcare utilization. So as you can see, there's a pattern evolving of not just kind of the burden of the illness on the patient, but So it's important as you're looking at the PHQ-9 that you do a good enough assessment of suicidality. If you look at depression alone, 50% of individuals with major depressive disorder do go on to attempt suicides. 10 to 15% are successful in completing suicides. So if you look at the relative risk of suicide in the mentally ill versus the general population, you see it's about 20.4 with MDD. You just take a look at the anxiety disorders, panic disorders, about 10, schizophrenia 8.5, alcohol use disorder. And of course, you know that in real world practice, these do not exist in these neat little boxes, right? There's a great deal of comorbidity that also exists, anxiety disorders, depression. So that again kind of increases your risk for suicides. 90% of suicides are due to a mental illness. So it's important for us to be able to look at that. And in the United States alone, 35,000 suicides per year. Worldwide, 10 million suicide attempts, 1 million suicide completions. We talked earlier about medical conditions. So I talked about cardiovascular disease. Cancer and depression, there's a very high link there. If you look at Parkinson's disease, 50% of individuals with Parkinson's do have depression. Generalized seizures, a very high comorbidity. Diabetes, the prevalence is anywhere from 15 to 27%. So again, no matter which patient you look at with a physical illness, it's prudent for us to be able to at least start to look at the PHQ-2 to see if they have comorbidities. Why is that important? Primarily because if the person is depressed, more than likely they're not going to take their diabetes regimen, the cardiovascular regimen. So if you start to address both of those issues concurrently, more likely that you'll have a compliant patient who then kind of really that translates into improved symptomatology, quality of life, and reduced healthcare utilization. Talk a little bit about hypothyroidism in a second. Other psychiatric conditions, bipolarity is another. Very often, if you have a patient with atypical depressive symptoms, hypersomnia, hyperphagia, you may think it's more kind of the atypical symptoms, but very often it could also be, you may unmask bipolarity. Maybe somebody who's manic but has presented in a depressed phase. Anxiety disorders, very high comorbidity. Substance abuse, we clearly are in an opioid epidemic here. So substance abuse, very often, rather than seeking help from a provider, they end up self-medicating just to kind of make sure that they feel good about it. Bereavement, kind of grief is something that one needs to address. So if you look at comorbidity among mood disorders and anxiety disorders, it's about 48% of patients do have an overlap post-traumatic stress disorder. 50 to 65% of patients with panic disorder. I think Nancy talked about kind of some of the panic symptoms earlier on. 8 to 39% of patients with generalized anxiety disorders. 67% with OCD. And again, remember, with obsessive compulsive disorder, you need a higher dose of the medication. So it's not kind of the normal kind of depression doses that works. 20 to 70% with social anxiety disorder. So just be aware and mindful of that. Anxiety, insomnia, agitation are risk factors for suicides. Now we all know that if you don't do a good enough investigation and you miss hypothyroidism, I know primary care does a phenomenal job in terms of getting that out of the way. But very often I advise my trainees, if you don't want to do a TFT, cost-effective would be TSH. Just make sure at least you've kind of ruled that out. Very often I end up getting kind of doing the second opinions in patients. And when they come in, it's like we do kind of a TSH and it's like off the wall. So, and they're on antidepressants, it's not working. It's not working for a reason. The HPT axis, the hypothalamus pituitary adrenal, the thyroid axis, is something that clearly plays a role in mood disorders. So again, very important to be able to at least screen for patients with any kind of thyroid abnormalities. And if you address that, more than likely the depression gets better. Also, cognitive impairments. What is depression? Depression is called pseudo-dementia. So again, trying to see hypothyroidism can also result in cognitive impairment, which again can mimic a lot of depressive symptoms. Clearly doing a thorough investigation in terms of other reversible workups, vitamin B12, folate, all of that is important. Anemia, chronic anemia can also result in individuals having some of these depressive symptomatologies. Now, how do you communicate the diagnosis to your patient? So first and foremost, I think it's important that therapeutic alliance plays a very significant role. You ought to be in a position to kind of relate this to your patient. How do you confirm, negotiate the diagnosis with your patient? How do you explain it? It's a knack. Medicine, I always say, is an art and a science. You could kind of have the best of scientific knowledge, but if you don't have the ability to communicate with the patient, half the battle is already lost there. How do you end up kind of minimizing stigma? Trying to look at if they are presenting with somatic symptoms. I have aches and pains. I don't think I'm depressed. Very often, kind of, they tend to trivialize the problem. So again, working with your patients on these issues. When we talk about diabetes or hypertension, it's very easy to talk about, clearly here is what you are deficient in, whether it's insulin, whether it's, clearly with any of the physical illnesses. Very often we don't do a good enough job when you talk about mental health issues. So the conversation that one needs to have is, if you look at the chemistry, the neurochemistry, which I know I'll talk a little bit about when I talk about mood disorders in women tomorrow. You have serotonin, you have norepinephrine, you have epinephrine, so monoamines. So clearly, there is kind of this disequilibrium in these monoamines, which plays a role in depression. And if you look at the vast majority of antidepressants, whether it's selective serotonin reuptake inhibitors, norepinephrine reuptake inhibitors, SNRIs, serotonin norepinephrine reuptake inhibitors, norepinephrine dopamine reuptake inhibitors like Wellbutrin. So all of these do play a role in kind of modulating the neurochemistry. So that's a conversation that you really need to have. There's already some amount of consumer awareness kind of in this era of internet. Everybody's on the internet these days, kind of trying to amass wealth with it. WebMD, you name it. There's so many sources out there trying to provide the right information, skiing all of this. It's important for us to understand the impact of untreated depression. So again, I talked about kind of how it can worsen the other comorbid medical illness. Suicide attempts, just in depression alone, 50% attempts, 10 to 15% completions of suicides. Risk for accidents increases. We talked about suicidality. Again, death related to substance abuse, overdoses, very frequent. So again, that's something that one needs to assess. Now, when one looks at it from a societal and kind of, family perspective, dysfunctional families, if you're depressed, you're withdrawn, kind of, you're not a part of this family unit anymore. The mother withdraws, kind of, clearly that has implications in divorces, the substances within kids in the family, absenteeism. I mean, that's a big area. Productivity, kind of, how do you construct and measure that? And very often employers, large employers, are constantly looking at what is it that we can do in terms of reducing absenteeism, improving productivity for our employees. So when one looks at treatment of mood and anxiety disorders, I talked earlier about kind of it's not just improvement in symptomatology or response, a 50% improvement, but we also need to start looking at remission. How do we prevent relapses? How do we prevent recurrences? Now, we have, as I said, an extensive armamentarium of medications to choose from: SSRIs, SNRIs, TCAs, monoamine oxidase inhibitors, mixed mechanisms, agents like mirtazapine, psychotherapy, interpersonal psychotherapy, cognitive behavioral therapy, and of course, there are novel modalities of treatment like electroconvulsive therapy, which clearly has existed for quite some time, TMS, transcranial magnetic stimulation, vagal nerve stimulation, magnetic seizure therapy, DBS, deep brain stimulation. Again, some of these are investigational tools, while others like VNS and TMS do have an FDA approval. What if a patient presents with psychosis alongside the depressive symptoms? Again, be aware that while you can add an antipsychotic medication to an antidepressant, ECT still continues to have very high efficacy rates, greater than 80% of patients. So it's compared to 65 to 70% with SSRIs, if you look at just antidepressant effects alone. So again, ECT is something that is kind of not used as much, but again, making sure you have the right diagnosis is key in all of this. So here's a great slide, which I always use by John Rush and his colleagues from UT Southwestern. So this is looking at response. So as I said, response, so when you look at treatment phases of depression, it's important to understand this. What is response? I told you earlier, with a score of, let's say, 24 on this, or a score of about 15 on the PHQ-9, there's a 50% improvement. That is a response. Remission is a higher standard. So if you use a scale like the Hamilton Depression Rating Scale, it's a score of about 7. Less than 7 would qualify as remission, which is minimal symptoms, normal function. Now, from remission to recovery, you really need to be in remission for a period of 9 months to a year to be able to be in recovery. Okay? So if you not reached recovery and you have a resurgence of your depressive symptoms, that is termed a relapse. But if you hit recovery and then have a resurgence of your symptoms, that is a recurrence. You with me so far? It's important to understand this. Very often, when you do your ICD codes, you say MDD, kind of recurrent type. Have you made sure that it's not a relapse? Right? Is it one episode with them having so many relapses versus having recovered and then having a recurrent episode? So it's extremely important to understand this. It's a great teaching slide. So let's talk about treatment. So non-pharmacological treatment interventions. I think it needs to start with education. I think awareness is key in all of this. Talking to them about the illness, as I mentioned earlier on, and also the options that you have in terms of treatment interventions. Exercise is key. Now, if you look at the neurobiology of depression, there are monoamines. There is the neuroendocrine, which is the HPA axis, the HPT axis, hypothalamic-pituitary adrenal axis, the hypothalamic-pituitary thyroid axis. You have various regions of the brain, which I'll talk about tomorrow in terms of what gets lit up, functionality of the brain, the morphometric changes that takes place, constant bombardment of CRF, corticotrophin releasing factor, in patients who are constantly stressed out, kind of exposure to stressful life events, which then has implications on neuronal kind of atrophy, or what is also termed as apoptosis, cell death. So you have significant atrophy in the hippocampi, and hence it ties into cognitive deficits in the patient. So when you do a mini mental status examination, you have memory problems, right? So all of this is connected here. So why did I kind of bring this when I was talking about exercise? So when we look at medications or when we look at psychotherapy, there are a number of changes that are being brought about in the human brain. So if let's say I give an SSRI to a patient. Now these are not magic pills. They don't work overnight. We all know that, right? So it takes about, a couple of weeks to about 4 to 5 weeks. Why does it take such a long time? Now when we give a SSRI to an individual, there is kind of this manipulation of serotonin at the synaptic site. So you have monoamines, which is serotonin, which gets increased at the synaptic site, which in turn kind of starts a cascade of reactions. Second messengers, ATP, cyclic AMP, to protein kinases to neurotrophic factors, brain-derived neurotrophic factors. So in a sense, when all of these changes are being modulated, what it then results is a neurogenesis. Who would have thought brain has the ability to kind of, to have this dendritic sprouting, right? Amazing. So hence the reason why all of these changes have to be modulated. So in a sense, what you are resulting in is not just symptom improvement, but also disease modification. Some may take much longer. Some may take about 12 weeks for them to demonstrate a response or the remission of their symptomatology. Hence, keeping them on the antidepressants if they're at least demonstrating some improved responses in topic. Now, there's increase in brain-derived neurotrophic factors. How does exercise play a role? So when you exercise, what happens? When you're looking at it from a biological perspective, there's an increase in VEGF, vascular endothelial growth factor. VEGF also increases BDNF. So you see the story emerging here, right? So all of this, when you exercise, you start to feel better. There is angiogenesis, if you look at it from a cardiovascular literature, but also has kind of significant therapeutic value when you look at it from the brain. Avoiding coffee, kind of if somebody presents with depression, anxiety, avoiding excess alcohol, good sleep hygiene is very important. You don't want to be having the TV on when you're trying to rest, right? Because if you're coming to me with difficulty falling asleep, middle of the night awakening, early morning awakening, I normally advise them to shut off the TV. Around 8:30, 9, take your medication, shut off the TV, and have something soothing that you can listen to, and then go to bed. So that's important to be able to talk to your patient about it. And again, what does their psychosocial support look like? That's important to be able to providing them with coping skills, problem-solving skills. My mentor clearly worked on resilience and vulnerability. How do you improve resilience factors, which includes coping skills, having good role models in your life, positive thinking. All of those do play a role. CBT, I know, Nancy did a phenomenal job on talking about cognitive behavioral therapy. So, again, when you look at the cognitive triad, you're looking at a negative view of self, the world, and others. So how do you start to correct those misconceptions that do exist? This distortion of cognition is what we work on. Something that's easy to adopt will be relaxation techniques. That's easy to do. As you breathe in, take a deep breath, slowly calculate 1, 2, 3, pause, hold your breath, 1, 2, 3, and then exhale 1, 2, 3. And that's a pattern that they can start off with. And you can even have your, if you have a social worker or somebody who can talk a little bit about CBT techniques. I know you're all very busy with patients that you end up seeing. You may not have the time to be able to do this. But again, giving them some tools that they can either work with some of the providers from within your networks or even doing it at home. And again, talking about having journaling at night is a very good practice. Let's talk about antidepressants. As I said, there are a little over 30 antidepressants that are out in the market. We all know, when we looked at tuberculosis, so it was isoniazid, which clearly the people were in sanatoriums. They also had experienced depression, and ipronazid, which clearly demonstrated some mood elevating effects. And that's how serendipity is what it made its way into psychiatry. And then, of course, since then you have an extensive armamentarium of medications to choose from: tricyclics, monoamine oxidase. In the mid-80s was SSRIs, you have SNRIs, SARIs, NDRIs, you name it. You have clearly a little over 30 antidepressants. So, how do we pick and choose antidepressants? Then here is a meta-analysis of antidepressant studies. And what you see here is if you look at the changes in the HAM-D scores or the MADRS scores, rating scales in depression. Look at SSRIs compared to NRIs, norepinephrine reuptake inhibitors, very comparable. Right? Look at the response rates. Again, it's in the 60% for both of those. So take a look at the symptoms that the patient presents with. If you want somebody who has insomnia, who's losing weight, you want to pick and choose an agent which clearly helps, which is sedating, number one. You want to pick an agent which clearly improves your appetite, right? So, for example, mirtazapine is a good agent. So, if somebody presents with depressive symptoms alongside weight loss, is also having problem sleeping, great agent to pick. So, again, trying to take a look at what does the patient present with, how do you match some of the side effects of the medication so that it gets to be the efficacy of the medication results in these side effects getting to be symptoms that can be improved with this particular patient. So there are, if you look at, you're delving into patients who have not responded to a couple of antidepressants, you've given them adequate trials, still not responding, what options do you have? You can do within class switches, right? Within SSRI classes, you can switch from one SSRI to another. You can do out of class switches. You want to choose something which is an NRI or an SNRI or an NDRI. You can do augmentation, and I'll talk about some of those techniques in a minute. You can do combination. So you can do Wellbutrin plus sertraline, which used to be called Welloft, right? Zoloft and Wellbutrin. So various combinations of antidepressants. ECT we talked about. Vagal stimulation. Again, you need to have clearly somebody who is proficient in that, administering VNS as well as TMS. So here are the augmentation strategies. So you can add lithium either to an SSRI, an SNRI, or a TCA. Thyroid is another, and I'm talking about T3, cytomel. So it's triiodothyronate, not synthroid. You can add another antidepressant. Stimulants can be used. So very often if you have somebody who's medically compromised, who continues to be depressed, I have them on an antidepressant, they demonstrate a partial response, this isn't really getting better, you can add a stimulant. Okay? You can either do a controlled substance or you can add an agent like modafinil, Provigil. That's another agent that can be added. Just to kind of give them that little bit of energy, kind of that oomph, the blah feeling kind of goes away with adding those kinds of agents. Buspirone is another. Buspirone has some agonistic effects at the 5-HT1A receptor, and so it has anxiolytic effects. So if you have somebody who also presents with comorbid anxiety, that's a great agent to use. Anticonvulsants, very frequently we use agents like lamotrigine. So that's something that you can use in depression. Dopamine agonists. Inositol is another. Pindolol is a medication that can be used, a beta blocker. And of course, you have a couple of antipsychotics that currently have FDA approval, used either in combination or as single agents. So the combination ones are agents like aripiprazole, which is used in concert with an antidepressant. The other is olanzapine, used in combination with fluoxetine. And then of course you have quetiapine, which is another Seroquel, which again is sedating, has anxiolytic effects, but also has antidepressant. So when selecting an antidepressant, kind of make sure you have the right diagnosis. Safety is key. There's an interesting study done by Peter Weider in this group. They looked at what are the more likely causes why patients are non-adherent to the medications. The top three were sexual dysfunction, weight gain, and number three was not being able to afford the medications, right? Sex, weight, and money. Universal concerns. You don't have to be a patient for that. So it's important for us to kind of, when we prescribe a medication, just get a sense, is this something that the patient can afford, right? So that's important to be able to consider. Again, making sure not just that you're monitoring the symptoms of depression, but also side effects. And the patient may be taking the medication once every other day. It's not going to work that way. You've got to take it consistently for all those changes to be modulated that we talked about from a neurobiological perspective. Work with your patient. Setting expectations is key. You've got to meet your patient halfway. Because to me, it's like I can prescribe any medication, fanciest medication in the world. But if the patient is not willing to take it. So again, letting them know, here are the two medications I think would work based on the symptoms they present with. You tell me which one you would like to kind of go with. And that makes it so much easier and palatable for the patient too. And of course, talking about what symptoms are going to improve first. It's not as if kind of the depression suicidality is going to go away in the first couple of days. It's sleep that's going to improve first. So just letting them know, here is the expectation. Setting expectations is very important. It's also important, like as the patient starts to get better, you also need to take a look at, is there some lingering symptoms, what we term as subsyndromal symptoms or residual symptoms? Is that kind of something that's still lingering on? This increases your risk for recurrences. So make sure to capture this. Otherwise, you come kind of 3/4 of the way through and then you have a setback. So just making sure that you're capturing sleep, the patient is sleeping from 2 hours of sleep has gone up to 6 hours, but there's still room for about a couple more hours. Make sure to capture that. Maybe he needs not just the antidepressant that the patient is on, but also maybe a sedative hypnotic that needs to be added in. That improves the rates of remission much faster. When you're doing a switch, be aware there are also discontinuation syndromes that do happen. So just being aware, don't make too many changes at the same time, because you won't know what's happening out there. Is it kind of just they're not responding to the medication A? Is it because medication B is being taken out? So just attempt one change at a time, just to be aware of that. And with any of these SSRIs, clearly there are high rates of discontinuation. And it happens with any of the medications. Reasons for stopping medications: I'm feeling better, doc. I really don't want to be on it. Adverse events we talked about, lack of efficacy, very common. So hence, kind of, PHQ-9 is a very good tool to use. So as you're monitoring, as we look at measurement-based approaches in today's healthcare, and that's how you're going to be paid, right? So making sure that you're capturing some of that along the way. Now, key messages when talking about antidepressants. They only work if you take it every single day, are not addictive, benefits from medication takes longer, and I gave you a rationale for why that happens. Continue antidepressants even after you start to feel better. Mild side effects normally, especially if it's GI distress the patients experience, that will go away with time as the medication reaches a steady state. Thinking about stopping medications, talk to your doctor. And the patient needs to feel comfortable talking to you about it, and hence therapeutic alliance. And the goal of treatment needs to be complete remission. I think in today's healthcare, it's extremely important for all of us to work together. Very often we have mentally ill patients who present with very high comorbidities of dyslipidemias, cardiovascular disease. I mean, very often it's like, how do we go about addressing some of that as psychiatrists? And same thing holds good within the primary care sector. So we really need to start looking at working together, looking more at integrated care models. So I talked about subsyndromal symptoms here. So again, this is a slide which clearly talks about rates of relapse, recurrence increases if you have more of those subsyndromal symptoms. Why isn't treatment working for me? Have I put the patient on the right dose of the medication? Very important, right? Right duration, as I said, a good rule of thumb was about 6 weeks on the right dose of the medication. But now, there have been studies funded through the National Institute of Mental Health, like STAR-D, stands for Sequence Treatment Alternatives to Relieve Depression, which have gone on to demonstrate some of these patients take much longer, 12 to 14 weeks, to demonstrate improvement. So again, adequate dosage, duration. Is there somebody who needs to get augmented with another agent? Am I missing something here in terms of diagnosis? Is there any other underlying medical illness that needs to be addressed? Substance abuse, which again, doing UDSs, random urine drug screens is important. Is there an access to pathology that we are missing? And very often there is, especially with mood and anxiety disorders. Comorbid anxiety, again, if you're not addressing the anxiety, just addressing depression, likely that the anxiety is fueling some of the depression too. And of course, is the patient taking the medications? So this is a STAR-D kind of trial I talked about, looking at response rates. So irrespective, they had about 4 tiers that they took patients through, looking at remission rates. But each of those tiers also had an augmentation arm and a switch arm. So they did not remit. This either had the option of switching, that the patient was a part of that dialogue, or they had the option of getting that agent that they were on augmented. So what you see here is the response rates. So very comparable, right? So 26% kind of if you had been switched from an SSRI, which was citalopram that they used, to bupropion, sertraline, venlafaxine. Very similar. Look at augmentation, very comparable. How long do you need to keep these patients on treatment? So if it's your first episode of depression, I normally advise them to stay on the medication 9 months, 9 to 12 months. Stay on the medicine. Second episode, at least 3 years. But if you do have other complexities, like you have histories of suicides in the past, you have a family history of depression, or you have bipolarity, stay on it for your life. And the same thing holds good if you've had 3 episodes. So remember, episode is after they achieve recovery. Subsequent episodes is what we call major depressive disorder with recurrence. What does the data look like when one looks at 1-year maintenance treatment? So if you look at citalopram, sertraline, very similar. And if you look at, once you take them off of the medication, look at the rates of relapse. If you were on medication, you did much better compared to if you were on placebo. Makes sense. Long-term maintenance trials is the venlafaxine trial, looking at cumulative probability of preventing a new episode of depression. So keeping them on it, 72% with venlafaxine compared to about 52%. When should one consider referral to a psychiatrist? So again, if there's diagnostic uncertainty, you really need to kind of look at, is this somebody who has some organic pathology going on? Does it's really require a neurologist or a psychiatrist working together here? Late life depression, again, looking at other complexities that can occur. Symptoms suggestive of bipolarity, right? So bipolar, again, very often there may be antidepressants that can bring up a manic episode, just being aware of that. Now, if you're looking at severe or kind of an urgent situation, especially suicide, so that might be something that clearly warrants kind of including a mental health provider within your treatment strategy. Patients having delusions, hallucinations, more in the psychotic realm. Is this somebody who needs to have electroconvulsive therapy, personality disorder, substance abuse? What about complexity? I've tried 2 antidepressants, I've given them an adequate dose, adequate duration of time, still I'm not getting that right response. So is this somebody who really kind of needs to be seen by a psychiatrist? What about side effects? So there are people who are extremely sensitive to side effects. So now we have pharmacogenomics looking at, there are amplitudes which can really look at slow metabolizers, rapid metabolizers, to normal metabolism and say, this is an individual who might do better with a lower dose of the medication versus somebody who might do much better with a higher dose of the medication. Maintenance, again, if its condition starts to get worse, is this somebody who needs to be referred to a psychiatrist or other comorbidities like obsessive compulsive disorder, as well as post-traumatic stress disorder, which can be a little bit trickier to treat. Now, when we talk about integrated care within today's healthcare landscape, it really needs kind of, our move towards more of a team-based approach. How do we work together? Whether we do it via technology, which I'll talk about tomorrow, we're using telehealth, and virtual integration, or collaborative care models, having somebody be co-located. In the 90s, when I was training at Yale, I was a part of a primary care group. As a psychiatrist, kind of a psychiatry trainee, we were a part of the primary care clinics. So trying to kind of start to move more towards that model versus a siloed approach which we currently have. I'm sorry this has like 2 slides superimposed on that, so just ignore the fluorescent colored ones. So if you look at those, this is a collaborative care model which looks at depressive care management. And if you look at that 82% up there, so if they had a psychiatrist or a mental health provider be a part of this team, the rates of them refilling the prescription is what they looked at of the antidepressant. 82% versus not having it is about 32%. So pretty impressive in terms of having a mental health provider be a part of your primary care teams in trying to look at this depression care programs. And if you look at the impact of depression management, response rate, look at the DMV model, 53% versus 33% is usual care. And if you look at remission rates, it's about 45%. So remission, as you know, is the highest standard, right, as compared to response. 28% with usual care. So there is enough data to suggest that we really need to start working together in trying to address these problems. So let me kind of end by summarizing here. So first and foremost, start with screening. PHQ2, PHQ9. The nurses who can kind of administer that within your practices, that would be the ideal way to go. Making sure you have the diagnosis right. More often than not, I get patients who are not getting better and kind of just do a good diagnostics on them and you find out they've been misdiagnosed. So kind of getting the diagnosis right is important. Engaging the patient, working towards remission, recovery as the treatment goal. If the patient has had an inadequate response, how do you go about kind of addressing some of that? Is it switch strategies, or do I have the dose right or not? What about augmentation strategies? Normally, a good rule of thumb is if you have somebody who is a non-responder to a medication, adequate dosage, adequate duration of time, I normally switch them. I can either do within class switches or out of class switches. But if it's somebody who is a partial responder, I then augment. So that's a good rule of thumb to follow. And of course, you want to make sure the first episode, stay on it. Even if the patient says, I feel better now, it's been 6 months, I'm doing really well, I would normally ask them to stay on it. If they really want to come off of it, the likelihood of them having recurrence is about 50%. So having a relapse before they hit the 9 months would be 50%. to just be aware of that. And of course, moving towards kind of working together and coordinated care models. So with that, I'm going to stop here and see if you have any questions. So which antidepressant are your first go-tos to women who are concerned with weight gain? So I would do probably go towards kind of, Wellbutrin would be something that you would choose. Bupropion would be a good option to kind of, start off with. Clearly, if you look at the SSRIs, some of the NRIs, each of those clearly has the propensity for weight gain. I mean, if you still say, let's say the patient does not respond to bupropion, you may want to kind of choose an antidepressant, but also kind of talk a little bit about lifestyle, kind of, are there, if it's more SSRI kind of induced stuff, are there medications like topiramate which can be added on, and the patient is doing well, let's say, an SSRI, but still gaining weight. You don't want to jinx that kind of, on top of the boat. So you want to kind of see if there are other agents that can be added on alongside the discussions that you have about, healthy lifestyles in terms of exercising, making sure they are on the right diet, they're eating healthy.
I have two questions. The first is in the 10 to 15 minutes we have to see patients. Is the PHQ-2?
I would go that route, yes.
PHQ-2. Is that adequate to know when to start medication?
Not for medication. I would still do a PHQ-9. If there is a way the patient is, so let's say you have the PHQ-2, it's already being done as the patient is waiting in the waiting area before you get to see them. Is there a way in which the nurse can give them a PHQ-9 based on if they answer yes to one of those questions? That would be the ideal way to do it.
Okay. The second question is, we do it. See a lot of patients with diabetes, and I do a fair amount of Contrave and Belviq. And when should we be concerned about serotonin syndrome in patients that are also on SSRIs and so forth? Is that a major problem?
So if the patient brings up symptoms that I'm having regular myoclonus, the patient is having kind of significant distress, autonomic instability. So those would be things, as you do the vital signs. So just being aware of that would be something that you, and also if they are on an SSRI that's not started by you, kind of working closely with that provider would be extremely helpful. And very often, unless you're working within a network wherein you have this, you share the EMR, it becomes very difficult. So making sure at least that you are keeping the other provider in the loop as to what are the medications that you have them on. And very often I find the patients here, they're so used to kind of going from one doc here to another doc there. They may even have providers, 2 or 3 primary care providers, especially when you look at pain kind of, and then they may be taking over-the-counter herbal supplements, right? St. John's wort or things like that, which also can result in serotonin syndrome. So I think what we all should do, given the fact that we have time constraints, is what are all the medications the patient is on? Either getting it from the patient, collateral source of information being their family or whoever they come in with, or providers that they're working with. It's extremely important.